Hello, everybody. I am Ira Kirschenbaum. I am the editor-in-chief of the Journal of Orthopedic Experience and Innovation. Tonight, I love when we have topics like this. This is a great topic. I think it's very cutting edge. I think it's emerging as a technique more and more, and I'm glad that we are the ones to be able to showcase this here and now. Um, I'm going to introduce the faculty for tonight. Tonight, we're going to be talking about quadriceps tendon allograft use in ACL and PCL reconstructions, both in primary and revision. We have great presentations and then hopefully a great discussion. Again, if you have any questions, type them into the chat. We will call on you at the appropriate time and ask you to unmute yourself and show your video, and we will ask the question and have a discussion with the faculty. If you don't, I'll read your question anyway. So let me start off. I'll introduce Brian Gilmer. He'll introduce himself. Brian?
Brian Gilmer. I'm an orthopedic sports medicine surgeon who's drifted into doing just knee surgery. I work in Mammoth Lakes, California, and Reno, Nevada.
Great. That's great. And we have Amit Mamaya, who
Hey,
is
Hamid Mama.
yep, who's over at Anna now. We commented that he doesn't usually have in his bedroom two twin beds, so he's waiting to start Anna tomorrow.
Exactly. Thanks for having me. I'm with Mamaya. I'm from Birmingham, Alabama, and serve as Chief of Sports Medicine and Associate Professor at the University of Alabama at Birmingham.
All right. So this is a great faculty. We'll start. We're going to start with a presentation. Each surgeon will present on the quadriceps allograft tendon and why it's preferred over other techniques they use and a variety of issues. If we can get the first slide up. All right, Brian, you're up.
All right. As I said, I'm Brian Gilmer. I'm going to talk a lot about soft tissue side of things. Dr. Mamai is going to speak about bone block use. My interest in this actually, as an initial acknowledgement, is it was my PA who first said, we're doing these quadriceps autograft ACLs, we're loving them, and we're getting such good results with them. Why don't we use the allografts in the same way? We were still using hamstring tendons and those kinds of things. If you want to go ahead and advance the slide, Todd. So when Allosaurus reached out to us, I learned that there is a lot of wastage of these grafts. And when we started converting to quadriceps allografts, I was noticing that they felt and behaved more like my autografts, and was really pleased with that. Dr. Mamai will talk a little bit more of the science. I'm just going to talk about a couple of different ways predominantly of fixing this. We're going to give you a little bit of background about Allosaurus and how these grafts are obtained. If you can go ahead, Todd. So they're representing about 10% of the donors here nationwide, 70,000 processed donors. But if you advance here, the amount of quadriceps grafts is really small by comparison. And so if you look of that 7,700 in April, just last month, the total output was only 400. So they're having a really high discard rate, and I thought that was really unfortunate. That's kind of one of the reasons I got involved with this tonight and wanted to highlight how the popularity and the things that you can do with an autograft or can be done with an allograft, and in some ways has those advantages. So go ahead, move forward. So these grafts come, and the amount of tissue is really surprising. When you're doing a autograft quadriceps harvest, you might think that the tissue is relatively small, but there's a lot of overgrowth, particularly in people in our area where I have a lot of skiers with overgrowth of the vastus lateralis and vastus medialis. And so when these are harvested, you realize there's a lot of collagen that's available. And so in PCL reconstruction, or in other cases where we've even created additional grafts or collateral work, you can often get two full-size grafts out of one piece of tissue. They're often, as you'll see soon, very long, over 110 in length. And because they feather out at the end, we can even fold them back sometimes. to make one really long continuous piece of tissue. And we'll look how that's beneficial in doing double bundle PCL reconstruction here in a moment. As I mentioned, I'll let Dr. Mamaya speak about the bone block. I'm going to talk about soft tissue. The tissue process is standard. There's graft procurement, there's donor screening, and I always still document that we're telling the patients that there's a small risk of disease transmission or rejection. But in my clinical practice, that has not been a significant thing that I am aware of a single case of. And so it's pretty highly proprietary how this is done. But needless to say, these are stored in the freezer and widely available. I want to also acknowledge Akil Nazar, second-year medical student from the University of Nevada School of Medicine in Reno. He really helped a lot with putting some of this information and taking these videos together. We're going to go ahead and go forward now, and I'm going to show you two techniques here. The first is I like to utilize the ruler as a template from the set. So every pack has a plastic ruler in it, and if you cut the millimeter side off, if you cut the inches side off where it registers the inches, it's going to show you just the millimeter side. And the width of that will be 10 millimeters in width. We'll sometimes trim it down. I'll talk about how we're using really 9s and a max of 9.5 now. And we'll lay this out on a tissue. I typically am putting the femoral end, being the end that's closest to the patella, and the feathered, more distal end into the tibial side. And you can see how much extra graft is left there. So we're tracing it out on the back table according to our template. We're going to change the angle here in a second and start to cut this. It makes a nice rectangular graft. And then this is typically too thick in diameter, and we end up tapering it down a little bit. I also routinely use sizing blocks to squeeze it into a size 9. So in this technique, we're going to be whipping down and fixing the suspensory fixation device at the end of the graft. This isn't always my preferred technique, but a lot of people like it. It makes the suture management a little bit less. And this is typically done with a tape reinforcement at the 20 millimeter mark, and then whip stitching around that through an adjustable loop suspensory fixation device, and then whip stitching it back up and tying it. So we're cutting the excess away, and then I'm cutting that extra length for all inside ACL graft to a 70 millimeter in length. We'll sometimes use some additional sutures to taper the ends or just trim the ends down to facilitate graft passage a little bit. We'll put 2 marks here, which you'll see in a second, if I can ever get that one piece cut off. And we're going to put 2 at about 20 millimeters. We're going to put just an initial suture and get an initial sizing block. Carly Dawson, my physician assistant in Mammoth, and Michelle Moore, my assistant in Reno, are usually doing this, and I am scoping the knee. What's great about this is that they're in the room ahead of time. They'll get that initially trimmed down. They'll take that initial measurement, and I'll already be drilling that size, so they'll call that out. With this adjustable loop device, it's on a small card, but really, from an agnostic point of view, you can use any company's adjustable suspensory device. You just use a piece of suture tape down the center, and then whip stitch just like you would if it was a large hamstring tendon. So we start at the 20 millimeter, you'll see it pass straight down. And then with each sequential pass, we'll work out towards the end. As we get closer and closer to the end, we'll pass it through the suspensory device itself. And so it's pulling from the end of the graft, and it's pulling with suture against suture. This has been biomechanically tested and validated as a fine way of doing it with the adjustable suspensory sutures and the strength of a number 2 suture or a suture tape. So this will be passed through there, and then whip stitching will continue back up. That'll be cut and tied here in a second. You have to be really careful not to pierce, and we want to make sure that the adjustable loop device slides freely through our loop. So we'll move it back and forth. And what's nice for the assistants preparing this is that we'll do the exact same thing on the other side. And you'll see here we're taking those free ends and then we'll tie them off. I will always pre-tension this to 20 pounds. We'll soak it in vancomycin. I have a slide on that in a second, and leave it pre-tensioned in a graft tube until it's ready. The total time for the prep on this is about 7 to 9 minutes. And so it's about as fast as I can have a femoral tunnel all set up and prepared. And my assistant is then coming over with the graft completely prepared on the back table, assisting me with the femoral tunnel preparation. We're getting into the room ahead of time and have all this set up on a free table. And here we've repeated those steps on the same side. So this graft will pull from its end. And this is a 9.5 sizing tube. These are infinitely reusable. They're probably somewhere in your sterile core, often forgot about. And I'll always downsize this half to ideally 1. And we're pulling the femoral side then into the graft tube and leaving the whole graft inside of it. It also has a few fenestrations where we'll flush it with vancomycin. And that's the prep for an ACL. We're going to advance to the next video, the next slide. And so just the highlights. You're only going to get 3 things out of these lectures, right? So I kind of hit the highlights. I've moved to 9mm diameters for smaller patients. There's data to support this, a paper in 2023 from Arthroscopy Journal indicating a lower risk of cyclops. Because the volume of the quadriceps allograft is higher, there's a higher risk of cyclops lesion. We don't want to alter our tunnel position. We don't want to overstuff the notch with too much collagen. I'll go up to 9.5, although the paper recommends that males staying under an average graft diameter of 9.25. This is Dr. Zarajani's data out of Emory. And so the people who are at risk, females with associated meniscal repair and male with graft diameters. And when I was initially doing these, we were doing 10s. I'll still use 10mm grafts in revision settings. Otherwise, standard graft is we're targeting a 9. Go ahead to the next. Vancomycin soak, multiple meta-analyses. Seth Sherman, notably from Stanford, 15-time risk reduction of infection rate. I do this with 1 gram of vancomycin powder in about 200 milliliters of normal saline. I dredge the graft through once. Don't leave it in there too long or it'll start to actually swell, and we want to fight that. And that vancomycin soak has shown no change in biomechanical properties. Finally, the graft tubes. This just facilitates your graft passage and makes this really easy. If we're getting an easy 9 with the initial sizing, we're compressing to an 8.5 and drilling a 9. And so we're always trying to compress at least half or full size underneath. And we'll often keep that in until it fully seats. It also creates a nice seal at the aperture, getting nice line to line. And we don't want any synovial fluid leaking that could result in cyst formation up the tunnels. Again, the compression in the graft tube, no change in mechanical properties, and that's been studied and documented. So here we're going to do a double bundle PCL. This has been a new addition to my practice. It's probably still one of the more difficult operations I do. Here we're showing just how big this quadriceps tendon allograft is. So I'm taking that same template, but for an AL bundle, I'm going to cut that same ruler 10.5 millimeters in diameter, so a little bit fatter, and 90 millimeters in length. That'll be for the anterolateral bundle. And for the posterior medial bundle, it'll be a little bit shorter. And depending on the size of the patient, I'm making that either a 6 or a 7. I'm going to lay them out with templates, make sure I like exactly what we're getting. Typically, a quadriceps allograft is going to be the thickest on its medial side adjacent to the VMO. It's going to taper a little bit laterally. So I'll take the smaller graft on the lateral side and the larger graft on the medial side. In all of these videos, just full disclosure, these are my assistant's hands. In both cases, in both facilities, they are much more facile at this currently than I am. Again, we're just going to trim off the extra sides, and you'll see how thick that tissue is. I'll sometimes take some of the additional thickness off of it. Just a very quick vicryl suture to preliminary size it, make sure we have a rough estimate of what that diameter is going to be, and then we'll size it more formally with a sizing block once it's been trimmed down and prepped with the suture. A lot of surgeons tell me, here you see me debulking some of the thickness. A lot of surgeons will mention to me that their graft actually gets bigger with the suture. I don't find that to be the case. In my practice, I find that I usually can shrink and squeeze it down half the size. This is actually my preferred technique. This is using X-Braid and the Stryker Pro Cinch suture. It's important on the posterior medial bundle that we're going to actually whip stitch from the middle out to both ends. And that's because this bundle gets passed first, but we need it to not accordion when the anterolateral bundle graft goes down and then back up into the femur. So 2 whip stitches that start in the center. That additional suture kind of helps it stay in place in the knee. And then we're going to leave a gap. I leave 30 millimeters that's going to go into the tibial socket, 20 millimeters that's going to go into the femoral socket. And we're going to create a space in the whip stitch that we will actually pass through that. And I like this better because the adjustable loop suspensory devices, in this case, the Stryker Pro Cinch, is going to be fixed at the aperture, shortening the working length of the graft and making conceptually a stiffer construct, possibly less wobble in the tunnel, possibly less windshield wipering. There's a very nice mechanism for this where we take a single suture, pass it across one direction, and that allows this is an open button system. The suture gets passed across. We put one tail into the suture, shuttle it across the graft. Then we use that same passing suture to shuttle the other suture the other direction. So now both white tails have come through, and they will move through this pulley system and convert in the button. So as they're shortened, you'll see them pulling up against the graft card here, securing the graft, and then we'll pull these tails and they'll bring them through and complete the button. So you can see the adjustable loop fixation device is at 30 millimeters. Here it's passed across, and now we'll complete a whip stitch in the same fashion on the other side. So keeping the graft prep similar on both sides is helpful. During this part, I'm in the back of the knee. The prep takes longer. Getting ready for the PCL takes longer. But my assistant will typically be ready at the time I'm ready to make a tibial tunnel. The tibial tunnel will be 10.5, and both of these grafts will fit down a 10.5 tibial tunnel. That's drilled at 60 degrees. That's been proven to give you the best congruency with the hourglass posteriorly and to give you the right angle and to minimize the interference with the roots. We also want the graft size. We want the, we're going to drill an 11.5 tunnel for a 10.5 graft and an additional 6. But we want that to be no bigger than 11.5, or you can start to destroy the posterior shiny fibers and blow out the meniscal roots, which unfortunately I've seen clinically when doing revisions. I wish we had time to show the whole PCL case, but that's the graft prep. So both bundles coming from a single allograft, a single 11.5 millimeter tibial tunnel, an AL bundle, I'm aiming for at least a 10 to a 10.5, 90 millimeters in length. Taking that extra 20 millimeters of graft, folding it back, using that thinner portion to make one even diameter solid piece of tissue. This tissue handles much more robustly than an Achilles graft, and it's big. You could go bigger if you wanted to make a bigger graft. There's plenty of collagen available. The PM bundle is smaller. I whip stitch over the whole tendon length, and that prevents the accordioning effect when the AL graft is passed on both sides. There's open adjustable suspensory devices on both sides, so we add the buttons as we go, and this facilitates suture management in what is otherwise a pretty difficult case. A couple of quick slides on, one more slide on this, Todd. Probably the biggest question somebody would have is double bundle PCL. Do I really have to do this? It is not easy, but it definitely works. Better biomechanical outcomes, that's documented. Less sag, less external rotation. If we're being really honest, most single bundle PCL reconstructions are still grade 1A 1B. Some of them are even grade 2. Better x-rays with the double bundle, less translation on stress x-rays, better clinical outcomes. I am using a tape type reinforcement on the AL bundle. And these patients have higher odds of normal and near normal. So a collegiate baseball player, for example, who I had, we were able to get back to sport with a PCL. I have been much happier with the way these knees feel and do clinically. And getting them out of the quadriceps allograft has been a big part of that, as well as converting to the double bundle technique. And with that, I can hand it off to Dr. Mamaya, but I don't know if you guys want to do some questions now about that, or you just want to do them at the end.
Looks like we're going to do them at the end, which I think is good.
Roger that.
I think we'll get the whole big picture, and we're doing well with time. So this works out well.
Sure. Thank you. Thanks, Brian. That was great. So as like Brian said, he gave a great presentation on kind of how prepping the grafts and utility of that. I'm going to go over some of the science and background on using quad allos or allograft in general, and then kind of go over some short videos also. So we'll kind of move on, and then disclosures are on the national website. So, a lot of people are very cautious when using allograft tissue for ACL specifically, right? This is a 10-year randomized study that followed patients with hamstring allografts, and they failed at a 3 times rate higher than autografts in a young athletic population. So a lot of people got worried, saying, do we ever need to use allografts at all in ACLs? The outcomes don't seem as good. Next slide. But then people said, well, then you got to worry, is it irradiated or non-irradiated tissue, right? Maybe all allografts are not made the same, so people started to argue that. And here's a systematic review of Flanagan's group here published that when they looked at autograft versus non-irradiated allograft tissue, they found no significant differences in graft failure rate, post-op laxity on KT1000, or patient-reported outcomes. However, the patients did tend to be more in their late 20s and early 30s, as clearly most case series with allografts tend to be. So it may not be extrapolated to the youngest of patients that are your high-risk 16 to 21-year-olds. Next slide. So here's another one out of Rush. Is there a higher failure rate of allografts compared to autografts with ACLs? They kind of looked at a whole overall global picture of them, and they found no differences in re-rupture rate or clinical outcomes. So I think allograft has to be in the toolbox of anyone who does a high volume of ACL and PCL surgery. Allograft, you can avoid a lot of graft harvest morbidity and other issues that happen with autograft in the right patient population. Next slide. So then we did a study looking at the effect of irradiation on load to failure, and specifically BTB allografts, because everyone thinks they know that irradiation causes this issue. Well, we looked at it and it was kind of strange. We found that load to failure decreased at intermediate doses of radiation, but low and high doses did not significantly change the load to failure. All this study told me is that we don't know, right? That it's a mixed bag. Everything's irradiated differently. You got batch irradiation. You got other ways to radiate these grafts. We really don't know, but what it sounds like is that radiation may not affect it as much as we think it does. It may not ultimately matter, but more to come. Next slide. So why did we go to quadriceps tendon? Similar to what Brian mentioned, actually, my interest in quad allografts came about because of my interest in quad autografts. Started using quad autografts back in 2017-18 time period, and really started to like them. And I said, hey, why don't we start doing this for our allograft cases also? Well, the quad tendon is very thick, right? Compared to your hamstring or patellar tendon. Compared to the patellar tendon, the quad tendon has 20% more collagen per cross-sectional area than a patellar tendon. The patellar tendon is actually quite thin. The ultimate load to failure of a 10 millimeter quad tendon is almost 30% higher than a 10 millimeter wide patellar tendon. Again, that comes from the increased collagen and the thickness of the quad. And here's an MRI just on a patient. If you measure out patellar tendon versus quad tendon, see the dramatic difference in thickness. Next slide. So now let's compare it to hamstring allografts. So a lot of us, have used hamstring allografts in the past. Why not just keep using hamstring allografts? Well, hamstring allografts, we oftentimes either quadruple them over for all inside, or we double them over with both the semi-T and gracilis. And are you really getting the equivalent tensioning of all those strands, really? And And we've also had second looks into some of these knees, and we may see a synovial layer form around the different hamstring tendons, but oftentimes if you kind of poke at it, you can kind of see this, the hamstring tendons and allografts still tend to be separate entities and not necessarily one piece of collagen tissue. Unlike the quad, which kind of basically, even though it has, you could argue that has layers, it behaves more like a single tendon rather than doubling over hamstrings. Next slide. So we talked about donor site morbidity. Why use allograft in certain select cases? Well, first of all, pain, right? There's a lot of pain associated with any autograft. Of course, hamstring seems to have the least pain. Quad has a little bit more pain, and then BTB has a lot of pain, a lot of anterior knee pain. We kind of just ignore it oftentimes, honestly, but up to 50% of patients have anterior knee pain with BTB autos. If you're taking a hamstring autograft, you're losing dynamic stability, right? Your hamstring pulls the tibia back, and it's a dynamic stabilizer. So do you really want to take away your hamstring if it's going to help you with that? You have strength deficit issues, right? We all know that it's very rare for a patient to get 100% limb symmetry in their leg, let alone at 9 months. They may never ever get it back. It's oftentimes a different leg forever. And then there's aesthetics, right? Just when you harvest a graft, a BTB, large incision on the center of the knee. So there's an issue with that too. Next slide. So again, this is one of the studies that just talk about strength deficits after, hamstring tends to have, quote, the least strength deficit issue, but you still have significant amount, 3 to 27% in this study for semi-T or semi-T plus gracilis. So again, these strength deficits are not only present short term, but they're also can be present long term. Next slide. So in my practice, when do I use allograft for ACLs? Well, typically I use it overall for, quote, older patients, but age, we don't just go strictly by age. We tend to see kind of what their demands are physiologically, how they are, what kind of sport are they. If it's a 30-year-old playing in a competitive soccer league 4 days a week, that might be a different patient from another 40-year-old who kind of just goes to the local gym and lifts weights, right? Very different patients. But in general, yeah, I start to consider it over age 25. Very rarely will I use an allograft in under age 25. I look for patients who are overall lower demand when we're talking about the ACL. Also, lower risk for re-tear, right? We're measuring tibial slope. If their slope is significantly increased, I'm probably not going to use an allograft in that patient. If they have significantly complex meniscal tears or they've had prior meniscectomies, maybe I may not go to an allograft. And then the multi-lig setting, oftentimes I'll go to allograft just because they're usually a polytrauma patient. I know I work at a level 1 trauma center. I do a lot of multi-ligs every year. And oftentimes they can't handle a harvest of an autograft. It's very rare they can handle that. So again, all these come into play. So I really don't want people to come away being like, oh, I use allografts for this age and I use autografts for this age. Really, it's a complex kind of algorithm that you got to kind of take account a lot of factors that go into it. Next slide. So let's go through kind of our ACL quad tendon allograft. Brian showed some really good video of preparation of it. So we're going to be pretty short on the prep side. But as you can see, we use a bone block here on our ACL and PCLs. The bone block's pretty large, so you got to kind of cut it down. We use a kind of a sagittal saw to cut that down to shape it. I like to get it to about a 10 millimeter plug. You can go 9. What I really like, though, is you can get a long length, right? This is the entire patella, so you can really get a long length of about 30 millimeters in length. Then we can pass some non-absorbable high-strength suture through the bone block. And then on the femoral side, I use adjustable tension system and have a button on that side. So again, this is going to go into the knee. You do your traditional tunnels. We drill anatomic tunnels. So you want to get your tunnel right on the femoral side, kind of pass some suture to maintain that. Then you go to your tibial side. We ream a full tunnel here as opposed to a socket. Then we pass our graft in. Buttons going up on the femoral side. That's the soft tissue side. Once we flip the button, we start tensioning and pulling up the actual graft. The graft's coming up. We dock it into the femoral side. Again, we're looking for a length of about 80 to 90 millimeters total length on our ACLs here. And then we get the bone block fully seated into the tibial tunnel. And if you get a 30 bone block, that's taking up a lot of your tunnel. I usually use a screw on the tibial side for the bone block. Now you're getting bone fixation to screw on the tibial side. So I love that. And we'll kind of go over some x-rays next on the next slide. So, one of the things I like, and you can do this either way. Obviously, Brian does all soft tissue. I tend to use bone on my the bone plug and preserve it. And the reason I like that is because sometimes people worry about osteolysis on your tibial side with allografts, or if you have windshield wipering inside there. So I really like the bone fixation on the actual tibial side and put a screw. Here's an AP and a lateral. Look at that. Look at that bone plug. Look at how long that bone plug is. You filled up pretty much the entire tunnel. And we've been doing this for several years, hundreds and hundreds of cases with allograft, and we have not seen any issues with tunnel osteolysis on this side. So I really like using the bone block on the tibial side. Next slide. Here's just a scope picture of what that looks like. Again, with the graft in place, the bone block kind of fills up the entire tibial side, and the graft goes into the femoral tunnel. Again, notice how thick and nice this tissue is. Again, like Brian mentioned, you do have to be careful. You don't go crazy and make it too thick for risk of arthrofibrosis or stuffing the notch. You certainly, I tend to try to keep my allografts in male patients around a 9, maybe a 9.5, and then females kind of 8 to 8.5. But again, based on your notch size, your gender, your patient size, so forth. Next slide. Here's a second look we had on a quad allograft. These grafts tend to incorporate really well. This is about 10 weeks after a quad allograft ACL. And we went in for a second look due to a lack of some stiffness and extension. And I'm pretty aggressive on taking them back if they're not getting their extension back. But this graft looks very well matured. Looks really nice, actually. Next slide. Here's an MRI on a quad allograft. We have a bone plug on the tibial side with this. You can see the edge of the screw right there. And you can see kind of how the bone is incorporated really nicely. Look at how thick and homogeneous that signal is on the actual ACL. And I'd venture it looks like close to a normal ACL signal. And then we have suspensory on the femoral side. Next. And so then go to PCL technique. Again, looking at we'll play this video. Again, we prep the graft again in very similar fashion. I tend to use a longer graft length, about 100 to 105 on the PCL. So you got to trim it down, kind of cut it to appropriate length. Use suspensory on the tibial side in this case, and use the bone block on the femoral side. So kind of flipped from what we do in ACL. And then we go into the knee. Again, we do anatomic tunnel outside in on the tibial side. So we drill a socket right here. Socket length, kind of usually take it back about 40 millimeters or so. Get on any soft tissue in this area. Then we do a pin on the femoral side around the 11 o'clock position, drill in a pin, followed by a reamer over this pin, and drill a full tunnel here. This is so I can get my entire bone block on the femoral side. We pass our graft down the femoral side. You'll see this then going into the tibia. It will dunk it into the tibia. We'll get that graft just to the edge where you see some purple marking, and we'll put a screw on the femoral side to fixate the graft. And then we'll tighten down on the tibial side and tension it appropriately. So that's your PCL technique for a single bundle, that is. And I really like it, again, because that bone on the femur can be soft sometimes, but you can get nice bony contact there in the tunnel with the screw fixation. Next. And so this is just some arthroscopic pictures of cases. Again, the PCL going back out of the femoral tunnel into the tibia. The top left is out of the femoral tunnel. Bottom left is into the tibial. Nice thick tissue. I never use autograft for my PCLs. I tend to use all allografts for my PCL so I can get appropriate length. And again, I think PCLs tend to do well with allograft. And this just shows, you can see the bone block on the femur with a screw next to it, and then you can see the button on the tibia. So our outcomes, we're actually in the process of kind of creating our database and writing up the study. But for our ACL quad allografts, we've had excellent PROs. Our retail rate's less than 3%. And we've used this in patients who are relatively active, who've wanted to go back to just life quicker and didn't want to handle autograft harvest. So some of these patients are still very active people in their 20s that go back pretty quickly. Same thing with PCL quad allografts, excellent PROs. Usually do this more often in the multi-lig. Again, I do about 55 multi-ligs a year with ACL, PCL, posterior corner. So those are where most of my PCLs tend to come from. We'll obviously do a few isolated PCLs every now and then, but most of them are in the setting of multi-ligs. So definitely use allograft in those cases. Again, I've had no re-tears on the PCL side. But as Brian mentioned with these cases, hopefully I hope to get grade 0, posterior drawer, but a lot of them do tend to go to grade 1 posterior drawers on PCLs, and that's kind of how they tend to heal with this kind of polytrauma. Next. So again, that's kind of my overall thought process on quad allografts. I think it's been a really nice, graft for my practice compared to I've used pretty much name every graft you can name on allograft side. I've used them all, but the quad allograft has been really nice for the thickness, and it also combines the bone side that I love, the best of both worlds. Thank you.
That was amazing. I want to encourage anyone to put some questions in or raise your hand or react in any way. I just want to start off with a question. Let's talk about the statement that was made, not all allografts are created equal. All right. So, Amit, why don't you comment on that? Because, when as a chairman, where I am at my place, I have to decide which companies I'm going to use. And it could spin your head when you're looking at, going from booth to booth. So what do you look at and why do you choose the company that you choose?
Yeah, that's a good question. It is confusing about the different processing techniques and so forth. One, make sure they have a good track record, of course, of testing the specimens. For example, Allosource is one that has very rigorous testing standards and sampling of their grafts to make sure there's no contamination. And number two is the way they process it. When they say for example, if you're talking about the field of radiation, they say, oh, ours are a low dose radiation or moderate dose of radiation. How do we really know that? Are they really being able to measure that? That's another thing you want to take a look at. And then if you want to do non-irradiated, do they offer non-irradiated grafts also? Because there is some thought that, non-irradiated grafts may perform better. And if you don't know which one's better, then perhaps go to non-irradiated grafts. Looking also perhaps at the age of the donor, there's some thought that the age of the donor may matter also. So a lot of those come into play when looking at companies, and also, of course, accessibility and availability. Right? Can the company give you the allografts you need and supply you with the allografts you need on a regular basis? For most of us that are higher volume knee surgeons that are doing a lot of cases with grafts, are you gonna run out and get behind on the grafts, or are you gonna have a readily supply of allografts available?
That's great. Brian, any comments on that or just
Well, it's a little bit of a sneaky trick, so I'm reluctant to give it up. But the truth is, to mention what I said in the beginning, a lot of surgeons aren't utilizing these quadriceps allografts. Now, the data supports that age doesn't really change the biomechanical properties, and there's some studies that show that. But if you have a preference on age, and you want a younger donor, say under 40, you're gonna have an easier time getting matches with quadriceps than you are with other grafts because they're less popular. But like I said, there's good biomechanical data to say that the age doesn't matter a lot. But currently, if you just look at how many grafts we're not utilizing, you can be a little pickier within that subset because there's more to use. And the thing that Amit brought up really well is I noticed a distinct difference between the physical exam when I converted from a quadrupled allograft with a peroneus longus technique to a quadriceps allograft. And again, independent of me, my physician assistant in clinic said, this patient had an allograft because the allografts used to always feel different and these feel the same. And so the quadriceps allografts feel like autografts, and quadriceps autografts feel better than hamstring autografts. And I would say if you lined me up and gave me 10 knees blindfolded, I could tell you probably what was what with about 70% accuracy.
That's great.
Again, not that they're all clinically unstable, but you can feel a difference, which means that's fairly different, right? If we think our fingers are good to about 2 or 3 millimeters.
That's great. Great answer. Hayden Harrelson, you have a question? You want to unmute yourself and maybe show your video or not? Hayden, you had a question? I'll ask it for you if you don't unmute. All right.
What's up, guys?
Oh, there
Sorry.
you go. Good.
Thanks for having me. Dr. Mamaya, can you talk about, you mentioned you have used every graft available to us, and B2B allografts seem to be pretty common. Can you talk about like your transition from using B2B to the quad tendon with bone? Seems like the quad tendon with bone in your presentation is kind of a hybrid, kind of best of both worlds. Did you feel like you completely eliminated just the graft tunnel mismatch with the allografts that were available to you?
Yeah, no, that's a great question. So when I ordered BTB allografts, I wanted to make sure the patellar tendon was not too long, but you can't always ask. I mean, everyone's asking for BTB allografts, so it's gonna be hard to kind of dictate what length of patellar tendon you get. If you get a long patellar tendon on a short female patient, I mean, there can be significant graft tunnel length mismatch between the two. And so that's really painful, right? How are you fixing it on the tibial side? You got half your bone plug sticking out on the tibial side. It can be quite painful. So the nice thing with the quad plus bone plug is that you literally set your length, right? You can set your length. Like I said, females, I tend to go with about 80-ish. Males, I tend to go about 90-ish. Really, it's based on height, not necessarily gender. And so you can kind of tension up the femoral socket and dunk it into the femoral socket. And then on the tibial side, you have your bone block, and these bone blocks that are coming on these quad grafts, it's the whole essentially the whole length of the patella, right? So we have a really long bone plug. So even if you kind of miscalculated, perhaps, you can afford to just cut that bone block down 5 or 10 millimeters after you've fully seated in the femoral side, and you still got about 20 to 25 in the tibial tunnel. You're not worried about it. So yeah, short answer is I've eliminated that issue completely from my practice, being able to use quad with bone plug.
That's great. I was going to ask a question about, we often ask in innovation Zooms, if something happened first, would you do this second? So, for example, bone patella bone was an early choice by quite a number of surgeons who popularized it. I know it started in the 60s, but really more popularized later. Um, if quads came first, would we even be thinking about bone patella bone? Because the patella tendon you point out is thinner. You have graft mismatch in, maybe lanky patients, skinny patients, short stature. So if the first pioneers did quadriceps bone autograft first, would we ever even think of doing bone patella bone, especially with the donor site morbidity found there?
That's a good question. I'll see what Brian says, but I guess my answer would be I feel like one day we might be looking back and thinking BTBs are quite a morbid procedure, and people are going to look back and be like, this should have been for like a last resort. Why were we harvesting so many BTBs and causing so much pain? Again, I use BTB autographs in my practice still all the time, so it's not like I'm downing that graft, but that's a good question. Would it have led to that? I think there were certainly problems with the BTB that led us to quad, but would there be as many problems with the quad? I don't know. Like Brian mentioned, maybe too many people would have gotten large quads, and we would have been suffering from arthrofibrosis left and right. And then someone would have done a BTB and be like, "Look, these are much thinner grafts. You don't have to deal with it." I don't know. See what Brian thinks.
So our this is a history lesson, and as somebody who runs a sports medicine fellowship, it's always fascinating to me because I get to treat new surgeons, and they always they always come from different places, but two, they're always from a different generation, and a different generation of surgeons I feel like is about 10 years. The simple answer is we started with BTB because that was the fixation that was available in the 60s, 70s, and 80s. It was interference screws. And so it's the changes in the technology that have made some of this possible. For example, if you look at quadriceps autograft, the longest you can take is about an 80. If you start harvesting up into the muscle, people get significant weakness and it gets very morbid. Well, if you take a 30 millimeter length, that means you're only getting about 20 in each socket. And if you're fixing all soft tissue with a screw, that's suspect. Bone, not so much, because that bony fixation is a lot more robust. So cortical fixation devices, endo button, early 2000s, adjustable suspensory devices early 2010s, that led people to say, gosh, dealing with bone blocks, then we have to open a microsagittal saw, we have to do these things. Sometimes the bone blocks break, sometimes there's this. I can always get that same length of tissue. Anybody can give me a 70. And if I can get cortical fixations on both sides, my tunnel lengths aren't as critical, my tunnel diameters, but it all hinges on being able to have a mechanism for cortical suspension on both sides. That's what makes modern soft tissue surgery possible. In the allograft setting, you can do exactly what Amit has done. You can use the bone block to give you some extra length, and you can still take advantage of the tensioning benefits of adjustable suspensory fixation. And so I think ultimately, to highlight what Joey does so well, the innovation and technology are in a feedback loop cycle, and they're feeding each other. So I think historically that's why we're finding this now and not necessarily the other way around.
That's awesome. A really great question. Hayden, you have another question? No problem. Go for it, Hayden.
Yeah, absolutely. And this is kind of piggyback off of what you just asked. So, if you look at, again, this is to the group, Dr. Gilmer, Dr. Mai, yourself.
You ate already?
If you look at ACL reconstruction, right? We started out as open, transtibial, then moved to arthroscopic. It's obviously progressed a long way. And, like Dr. Mamaya mentioned, his indications for allograft seem to be getting lower, like broader, as the results are better. So now with industry, you have better graft options, better graft availability testing, and then you have things like suture tape internal brace. There's things like the BioBrace that are out there, which is like a collagen brace for the graft. You have the Bio ACL, which is backfilling tunnels. Do you think in our lifetime, just your opinion, there's going to be a perfect recipe that will eliminate autograft ACLs? Like the next several generations of surgeons are going to look back at these massive B2B incisions and be like, oh my God, like what were they doing, sort of thing? Do you think that is an option?
Brian, I'll let you take that one first.
I'll be dead or hopefully at least retired. But no, I don't think so. I think we get better, but never perfect, right? I don't know. Look at, you were talking about baseball or basketball, or look how the way the game has evolved, but the game isn't going away. Patients are demanding more and more. And as we get better, patients just keep pushing the expectations further out. So I don't think this ever ends. And that's either exciting or super depressing. It just sort of depends on who you are.
One of the things I've always thought about, and probably maybe my next study, I'm in the middle of a randomized controlled trial of quad versus BTB right now, almost finishing up enrollment. But Brian, what are your thoughts on, you have a patient who could maybe do an allograft, but you really want to do an autograft because overall studies have shown that a lower rate of re-rupture. But what about an allograft with some type of biologic, some type of synthetic suture to protect it, and an LET? What if you threw the entire kitchen sink with the allograft and then compared to that with the autograft? Brian, if you were 21 years old, would you take a re-rupture rate of, let's say, 8% with the allograft plus the full kitchen sink versus 6% with the autograft? Which one would you choose?
I think you're leading into a really exciting thing. I think two things to follow on this. One, it's outside of the scope here, but repair. There's that whole arm of repair. There's that. There's still going to be people that aren't great repair people. So reconstruction's never going away. But to your point, biologic augmentation of allograft ACL will probably become an evolving trend in the next phase, right? The next generation of surgeons, the next 10 years, let's say. Because I think step one is optimizing the mechanics. We're pretty good at that. Step two is optimizing the biology. We're not very good at that, but we're getting better. So I think you're right. And the question sort of becomes who and how do we pay for that? Because the re-tear rate of these, and in prepping for this, I was kind of looking for long-term studies, quad allograft compared to, what you really want to know is not quad allograft compared to other allografts necessarily, right? Or what you want to know is quad allograft specifically compared to quad autograft, because most studies of allografts lump them all together. Tib ants and Achilles and everything's in that pot. And so, but as we know, they're not all the same. And so, some larger scale studies specifically on this allograft, I think, will be helpful, because anecdotally they're better. And then we always have patients that teach us. I had a 14-year-old who came here from a country. This is a ski town for those who aren't aware, and they came here specifically because they wanted an allograft, and I was extremely nervous about that, right? But that because of the concern of losing essentially 2 seasons of skiing due to the morbidity, and they push the indications in every possible way it can be pushed. That patient is now 18 years old and has not had a re-tear, and I stay in touch with them. So for what that's worth, I don't, it's one case, but these individual patients teach you a lot.
Absolutely. We have a question from Alan Resnick. Alan, you want to unmute yourself, maybe unvideo yourself, if that's a word, on video.
Fine. All right, I think I got it going here. I'm in the casual mode here. I got a little sweatshirt on at home. Yeah, so a couple of things. I mean, I was glad. First of all, comments are great. The talk is great. I am a huge fan of allograft in my own practice. I use it a fair amount, mainly because I had high-level skiers that were older, and as soon as I took their tendons, they were destroyed. And I had one guy who was in his late 60s who skied the Alps every year, and I never forgave myself because the patellofemoral pain never went away, and I always thought I was doing the best thing on earth for him. And it was terrible. And then I started to move those patients down lower and lower. And now I offer it to everyone who will take it because they all do better. I want to question about the notch impingement. When I do BTB allograft, which is what I primarily do when I do allograft, I found that the more anatomic I make it, the less and less required I have for notchplasty. In fact, now I almost never have to do a notchplasty in the cases. And I know that the grafts are much thicker in the quads tendon. Are you having to do notchplasty with the quads tendon, or is that less an issue too for you?
I saw
I'll
a
do a
picture of notchplasty on a meet, so I'll let him go first.
yeah. Yeah, I saw all base. First of all, if it's a narrow notch, pathologically narrow notch, I'm certainly doing a notchplasty. If it's a quote normal notch, I will do a slight touch-up notchplasty. Not that I think you need it, but my thought is maybe it adds a little bit of biology to that area. Yes, you're already drilling a tunnel. What more biology do you need? I totally get it. Some cases don't drill or don't do a notchplasty at all. But I think your native knee was your native knee. That person didn't tear their ACL until they tore it. So why not just slide in a quad, graft or whatever choice of graft in as you need to. But yeah, so for pathologic ones, for sure. For other ones, just a little touch-up notchplasty, perhaps.
And just a different follow-up question on that. Brian, did you ever thought about the notchplasty? I'm sorry, I didn't get a chance to let you answer.
I wanted to say I love the comment about the skiers. I treat care of skiers, and that shades what you do. So who you treat shades what you do. I love your comment on that. I have the same experience. 2, I almost never do a notchplasty. When the quad is in, I keep the camera in, bring the knee to extension, and if I see it impinging on anything, I will only then grafts already in, bovie a little, burr as necessary, but it's rare. But I will actually take the knee to full extension, take a picture of it in extension,
Yes.
and watch it as it goes all the way down. And if it's not impinging, I leave it alone.
Yeah, I do that as well, actually, with my cases, and I find it's amazing. The better you are at placing the graft, the less you need an notchplasty. That problem goes away. It took a while to accept that, but that's true. The other thing I've been doing for a long time, and I wonder if anyone thought about this, is that when I do my tibial tunnel for PCLs, and I actually do this for root repairs as well, I drill from lateral to medial to reduce the hard angle from the PCL exit to the PCL insertion. Just like you do the ACL from medial to lateral, I do PCL from lateral to medial. And that gives you an advantage when you have a multi-ligament and also when you have to do a medial root and a PCL at the same time. Or an ACL and a medial root, I'm sorry. That's an advantage because tunnels are coming from different directions. Anyone doing that or know anything about that or thoughts?
Yeah, no, certainly a viable option. I guess the multi-lig setting, I've gotten used to just making my ACL a little bit medial, anterior, proximal, my PCL moving it down a little bit more distal and lateral on that thing. But I generally try to just keep it to that one incision just from a flow standpoint. That's worked. But no, certainly there's no harm in obviously going lateral as you need to.
Yeah, we got one last question from Jerry Dahl. You have
Yeah, I just unmuted myself. I was just curious if either of you change your graft choice based on a contact sport athlete versus a non-contact sport athlete, or has the advancement in technology kind of got rid of that whole argument? I'm aging myself, but it used to be that, you wanted bone in both tunnels. For the football players and the non-contact, it was all soft tissue. And maybe the quad, and that's maybe a part B to this question, is it just using the quad with bone versus just all soft tissue?
all right, who
Yeah.
wants
So just to clarify your question, are you talking about is this the graft choice for autografts or for allografts or for both?
Well, it's mostly for football players. So we're probably talking about
Young,
16 to
18 to yeah.
32-year-old, right?
Yeah.
And
So
so
let's assume we're using an autograph just for purpose of this question. Short answer is no. I mean, I guess a disclosure again. I'm doing the randomized controlled trial, so it'd be weird if I preferred one or the other at all. But no, I think there's been recently published data. Pat Smith has some good data about 60 of his quad ACLs, no re-rupture rate at 2 years, doing very well with PROs, 90% return to sport. I think a lot of people believe that quad auto is not as good as BTB auto out there, including some of the people I've trained with in the past during residency. But I'll be honest, I believe that both grafts are viable options, both behave similarly in terms of outcomes and re-rupture rates. I don't have a problem with either one. And I think most contact versus non-contact, I think most ACLs tear in a non-contact mechanism. So it's not really the contact part that gets me worried, right? I'm more worried about a female soccer player than I'm a football player, to be honest.
Yep. Brian, we're going to start
So
wrapping up. So answer a question and say some final comments. We are being exposed to the fastest hour in orthopedics, a Joey Zoom open mic. It's faster than you guys doing 3 ACLs and before 9 o'clock. So
your practice is colored by who you see, or it should be. I think a lot of that BTB conversation you were bringing up has to do with the culture of contact sports and football. I take care of a lot of skiers, and they do very, very well with soft tissue quads. They do not like anterior knee pain. That's part of why I started doing quad autografts. So that's my answer on that. If I was, like I said, doing that, but it's just not my patient population. U.S. women national soccer's Bert Mendelbaum. I know his practice pattern is for all of those females, including those young high-risk females, are autographed quad now as well. So that's where soccer is going, at least from one leader in that field. Final thoughts. Just appreciate everybody showing up. If you have any questions, I am always reachable online and happy to go through these techniques with anyone. We're also going to post some technique videos, Amit and myself, to the Allosource website, and they'll have different companies' equipment and different mechanisms of graft preparation. So those can be good resources if you think you want to do this. And I'm always happy if somebody wants to reach out. Thank you so much.
Amit, some final questions to bring us home.
No, yeah, appreciate it. As always, I learn more than I teach on these webinars. Appreciate all the questions, and again, just keep the quad allograft in mind for your cases. It's something that shouldn't be wasted. It has some great properties.
This has been a great session. I really want to thank everybody. I'm posting into the link a link for this is an AAOS webinar with talk about the bylaws tonight. If anyone wants to go on to that, the link is there. But I want to thank Brian and Amit and all the people who asked questions for really enlightening Joey Innovation Talk. And I want to also thank our sponsor, Allosource. Really, thank you so much.